This year at ASCO as well as at EHA, we will have the first result of the trispecific antibody. It's called JNJ-5322. And a trispecific antibody is a follow-up of a bispecific antibody. And I think bispecific antibodies are more well known in myeloma and also in nodosis care, because they bind to a T cell, and with the other side they bind to the plasma cell, the malignant plasma cell, and they will kill, because of close proximity, the T cell can kill the myeloma. And the trispecific doesn't bind with one side to the cancer cell, but with two sides. And we hope that with the two-sided binding, we will have a more effective strategy, but also treat more patients with it, because not all the patients had all the antigens present at their surface from the cancer cells. So we have more trispecific antibodies. We had some abstracts already at ASH, but this is the first time that we have oral presentations with larger cohorts of a trispecific antibody that binds CD3, and on the other side BCMA and GPRC5D. So a clinical trial has several parts, and these are the results of the phase 1 part. And phase 1 means that the drug is given for the first time to patients, and you have to figure out what is the best way to give it to patients. So, for example, with bispecific antibodies, you have step-up dosing, and we also have that in the trispecific antibody. But in the end, we found out that we only need one step-up dosing. Then the other one is, what is the best dosage to give to patients? And with classical chemotherapy, we had a dose-limiting toxicity, but we don't have that anymore. With immune therapies, you can go as high as you want to go, but you don't need to go that high. And that's why we always try to find the dose with the highest efficacy, and they call it the recommended phase 2 dose. And if you have that dose, then we have to figure out in which frequency we have to give it. Do you have to give every week, or do you have to give it every 2 weeks? And in the trial, we found out that we can give one step-up dose, and then we go to the full dose, and the full dose, we dose it only once every 4 weeks, sub-Q. So it's an injection under your skin. It's not via a vein, or you don't need a intravenous access at all. So the results were just amazing. In the beginning, we had patients that were included that already had bispecific antibodies treatment, like an anti-BCMA bispecific antibody, and they enrolled in the study as well. And they already had a response rate of 55%, which was already amazing for these type of patients. And some of them, for example, had CAR T cells. But at a later stage, we moved to patients, and in total there were 36 patients that were treated who were bispecific naive. That means they did not receive any bispecific antibody before. And they had a response rate of 100%. Everybody was. So that's much better than the bispecific antibodies, because there you have an efficacy rate of around 60 to 70%. So this is small group, I must say, but it's 100%. So it's very, very exciting. I said that you have a drug in the relapsed refractory setting with this type of response rate, and we only see it with CAR T cells. So it's even better than some of the CAR T cells. So it's really, really exciting. So the results mean for patients at this moment, it's still a trial. So, but I hope with these results that they can bring it to a registration with FDA or EMA, and then of course reimbursement in countries, so it will become available. That will take some years. I must also add there is toxicity of this drug. So it's not that it's without any toxicity, and it has the toxicities of the typical BCMA bispecific antibodies. So that's mostly infections. So patients after receiving step-up and full dose, and in month 2 or 3 when they are in remission, you have to be on antibiotics forever, and you have to start with IVIG or subcube IG additional treatment, because you really need to safeguard you for severe infections. The other side effect of GPRC5D is mostly taste, loss of taste, a dry mouth, sometimes skin toxicity, and that's seen much less with this tri-specific antibody. So it's a different binding site, for the GPRC5D, which has some of the same effect on taste and skin, but it's much less severe than we saw with the GPRC5D antibody like tatetamab. So it's much better tolerated by patients. So I'm very happy I could put some patients on the trial and they're doing so well. So I think the advantages of this type of treatment is that it's a available drug. So it's not your own CAR T cell that has a huge produce. You have to wait for that. It's there on the shelf. So you can start it, and perhaps in the beginning you can be admitted. Sometimes you can do it outpatient clinic, because also cytokine release syndrome can be a side effect. It's seen in 70% of patients, but it's only grade 1, so it's very good and manageable for physicians. And I think then you have an outpatient treatment with a subcutaneous injection once every month, and your disease can remain in remission. So that's, of course, what everybody wants dealing with this disease, multiple myeloma. So I think it's very effective, but also the way to deliver the drug to patients is very convenient.